All right. Hi there, everyone. Welcome, welcome. It is top of the hour, so we're going to go ahead and get started. Welcome to tonight's evening webinar, free webinar presented to you by Archer Review. Tonight, we're going to talk about dermatology. For those of you who don't know me, my name is Hiva Kolodrovitz. I'm a family nurse practitioner. I've been practicing as an NP since 2015. I'm now currently in primary care, and I started out in family practice, specialized, and now back in the primary care world. So tonight's lecture is about dermatology within the primary care setting. So if you want to go into dermatology, you're going to know a lot more advanced derm than this. This is really intended for that primary care setting. That's what we're going to talk about tonight. So let's jump right in. A few disclosures before we get started. Remember, Archer is now accredited by the ANCC, which is amazing. American Nurses Credentialing Center has awarded us credentialing, meaning that we can give out contact hours for these free webinars and other content that we have for you that are paid. So if you are participating tonight through Zoom, you are eligible to get one contact hour if you stay for 80% of tonight's webinar, which is really exciting. If you're not with us in Zoom, that's okay. Just plan for it next time and just enjoy the webinar tonight. If you're joining us on the YouTube channel or Facebook channel, just plan for future webinars. I'm giving another webinar tomorrow on EKG review. Just make sure you sign up through that Zoom account to get that contact hour. Some learning objectives that we're going to cover tonight. So we want to talk about, remember, we're talking about that primary care setting. So common skin conditions, including skin infections, rashes, benign versus malignant conditions. These are things that we really need to be watching for and making sure that we catch. The nice thing is skin cancer is pretty slow growing, right? But we want to make sure that we're educating our patients about sun protection. We're watching for those malignant spots, and we're referring patients when appropriate. So we're going to talk about those common skin conditions and what's benign and what's not benign, more towards malignant. We're also going to have you be able to explain assessment, diagnosis, management of these common skin conditions. That's really important. You guys are going to be managing a lot of these conditions, both in your pediatric and adult patient population. If you're a family nurse practitioner student, you're going to see all peds, adult. If you're adult gerio in primary care, you're eligible to see 13 years and up. You know your scope of practice. So really being able to manage these conditions in both peds and adult is what we're going to talk about tonight. And then last but not least, demonstrating understanding of those warning signs. So when is it something more acute that needs that higher level of care? So that's really important. I always make sure to hit on those in my lectures just because you don't want to miss something that needs that immediate attention, right? So that's really important. All right. So for those of you who've done my webinars before, you know I love my Slido. So if you are on your computer, you can go ahead and scan this QR code with your phone and you kind of toggle back and forth. If you are on your phone, you can do both at the same time. I've done it before as a student. It's a little bit tricky, but you'll be able to see the webinar on your top screen depending on your phone. If you're just on your computer and you don't want to be on your phone, you can also just go to slido.com and put in this hashtag derm your review for NP, and you'll be able to join us in Slido. So I really like Slido because as I'm going through those questions tonight, we're going to go through questions directly from our question bank that are going to be more boards type prep questions. I'm going to be really asking you to engage with me in Slido just because we are on Zoom and YouTube and Facebook. This will really kind of get us all in one space. I'll do my best to look at the chats while we're going through, but it's a little bit better just to feel a little bit more cohesive in one space. We also will launch a few polls just to get us going tonight. If you're on there, you'll see that our first poll, who's in the audience, is up there. And I really like to start off with this question because I want to know who I'm talking to tonight, right? So tell me a little bit about yourself. The nice thing about Slido is that it's totally anonymous. So when you put in your response, you can enter your name if you don't want to be anonymous. I see some friendly names and faces in the audience tonight, so you can always do a little shout out and say, hey, I'm here. But if you want to remain anonymous in Slido, you can. So that's really nice. And so go ahead and put in your response and tell me a little bit about who you are and where you are in your nursing journey, because that will really help me be able to tailor my presentation tonight to you. And I see some people are putting things in chat. Mine says, what topics do you want to see? I think you might, Anna, you might be in a different Slido from a previous presentation, because it should be poll one and who's in the audience. Because usually we always say what topics do you want to see in our last Slido of the night, just to make sure that we are listening to you guys and making sure that we provide those webinars that are relevant to your learning. So I see a lot of people putting things in chat. I see some people putting things in Slido. Please go ahead and engage with me in the chat, in the Slido. But I see some new NPs. Congratulations. That's really an exciting time. It's also a very nervous time. Tell me, have you found your first job? Have you sat for your boards? How are you feeling? I have some NP students in my clinical rotation, so that's great. You just finished that year of didactics, so now you're getting in your clinical rotation. It's a really nice time. I remember I specifically asked for dermatology rotation because I love derm. I love skin conditions, but that's just me. Not everybody loves to really get in there with those incision and drainages and doing all those procedures. I see BSN student NP, congratulations, welcome. Medical assistant nursing student working in dermatology private practice, that's great, awesome job. So maybe you're considering going back to school and becoming a nurse practitioner, or you just want to beef up your own knowledge about dermatology. That is awesome, welcome tonight. Excited and nervous for my new job, FNP, that's great. I know it's definitely an exciting but also nervous time. And then NP student graduate, about to take my board soon. Very good, you guys. Awesome job. Planning to study for 6 weeks. Yes, you definitely want to make sure you don't spend too much time between school and sitting for the boards. The information is the freshest in your mind when you've just completed your studies. We have a 3-day live review coming up at the end of this month, and we can help you guys really hit those high yield content areas so that you feel confident going into your boards exam. So that's going to be really helpful for you. Check that out. Especially if you have 6 weeks time, you definitely have time to participate in our 3-day live review. Graduate, waiting to take the exam. Awesome job, you guys. You can also pop in there when you're taking your exam. I'm curious to see, because I know we're getting to that point in May where people are graduating. And then this one is, where are you from? So tell me, I usually get some international students, a lot of students from all over the states, which is really nice. Charlottesville, Pennsylvania. I myself am in Texas. So I am originally from the Boston area, did all my training in Boston, thought I was going to stay in Boston, and then life took me out to California. So I've practiced now in Massachusetts, California, and now Texas. And we've been in Texas for quite a while. So it's kind of fun to see all the different states and healthcare and the culture in those states and how everyone's doing it. But I see some sunny California. Shout out to California, Michigan, Florida, Ohio, Northwest Florida. I think is that what that says? Very nice, you guys. Well, welcome, welcome. And our next one. So, what topics are on your study plan for this week? So, I know a lot of you said you're sitting for your boards exam or planning to sit for your boards, and some of you said you're doing a 6-week study plan. What is on your study plan this week, and how are you coming up with your study plan? Do you guys need some help with your study plan? We have some really great study plans. We have 2-week, 4-week, 6-week study plans. We have mentoring that really helps you get that study plan in place if you just feel like, you know what, I need a little help with that study plan. So I'm just curious, what are you guys studying? Are you guys studying dermatology this week? Derm and cardio. Oh, those are my loves. So that's kind of perfect for this week for you. We're doing derm tonight and then cardio tomorrow. That's great. Need some help in study plan. Yes. Whoever said that, definitely reach out to me. If you can't find a slot in our mentoring, we can help you with that study plan. And I'll put up a little QR code at the end too, so that you can get some more information. You have my email on that slide too. So I'll definitely give you my email. HENT and derm entering into my primary care rotation for summer. 1 year left to go. So studying everything again. Yes, that's so true. Utilized Archer study plan, very effective. Oh, I'm so glad. Respiratory system. Very good, you guys. So this is really relevant for a lot of you in your study plans this week. That's great. So this one is a poll that I'm going to ask in the beginning of today's webinar, as well as the end of today's webinar. And remember, I talked about the ANCC accreditation. This is going to really help us make sure we maintain our accreditation and also help me really tailor these lectures to the audience. So I want to know, how confident do you feel now before we start the lecture? And then I want to hear, how confident do you feel treating common skin conditions at the end of our lecture, so I can really see if you guys feel better after we present the material or if we need to adjust the material. So it's a really nice way for us to tailor these webinars to the audience. So I see we kind of have people all over the board. So some right in the middle, some on the end of not feeling confident, and someone feeling really confident, 14%. I'm guessing that's the medical assistant that works in dermatology and primary care. You probably know a lot, right? You see a lot, you learn a lot working in the field. That's so great. My goal is to really get everyone to the feeling really confident by the end of this webinar. So I appreciate everybody putting that in. All right, you guys. So those are our fun polls. I always like to start off with some fun polls just so you guys can get used to Slido if you haven't gotten used to it before. And then when we're going through those practice questions, then it's a little bit easier for us to engage in that Slido. So that's really great. All right, so let's jump into those benign skin conditions. So this is going to be really helpful if you're seeing those pediatric patients, right? Milia. What is milia? This is really common in that newborn skin. Typically, we'll see this in those first couple of weeks of life. Those are those tiny white, pearly white bumps. Mostly you'll see it on the face, but you can also see it on the upper trunk and the extremities as well. And every once in a while, maybe you'll see some on that genital area. And these are basically just cysts filled with keratin. They're totally benign. Some new parents get really nervous about it, thinking that it's acne, and they want you to tell them what they can do about it. They come in and say, I've been scrubbing baby skin. Hopefully the nurse in the hospital has already educated on them on the fact that these are benign and they will go away on their own over time. But you're going to have to do a lot of reassurance with parents on this one. So totally benign. They will self-resolve. Please don't scrub it, right? Really gentle washing is really important. Don't pick at these because it can then cause scarring. So rule of thumb with dermatology, do not pick at it, right? And this is something that's really hard even for me, knowing that. But whenever I get that pimple, I'm like, oh, I want to pick at it. It's really tough, right? So you have to tell your patients, if you pick at it, it can lead to scarring. And we'll talk about acne in a little bit of why we shouldn't be picking at acne either, but you do not want to be picking at these skin lesions. So you want to really make sure you reassure parents and tell them it will self-resolve within a few weeks of life. Next one is cradle cap. This one's also really common. You guys have probably already seen this in clinic. You'll definitely see it in your clinical rotations if you're seeing these pediatric patients coming in for those first few visits coming out of the hospital. This is a form of seborrheic dermatitis, right? So it's dandruff in adults and it's cradle cap in our newborns. So this is really that yellow, flaky, greasy, crusty, scaly on that skin, on that scalp usually. Sometimes you'll see it on the face too. We don't quite know the etiology, but it's thought to be a mix of that maternal hormones and overactive sebaceous glands. Again, this is totally benign. You want to reassure parents it will self-resolve, but gentle washing with shampoo, with baby shampoo, and using one of those little soft brushes to help loosen those scales can be really effective. Hopefully, I remember when I had both of my babies, especially with the first one when I didn't know what I was doing as a mom, I took everything home. If they have a good nurse, they will encourage them to take everything home. And in the hospital, at least they used to, when I had my babies, they used to give these really nice, great soft brushes. You can probably buy them at Target and over the counter now, but you definitely want to use some of those soft brushes to gently loosen those scales so you're not like really scrubbing. So again, reassure the parents, gentle baby shampoo, soft soft brush to loosen those scalps. If it's really bad and really more severe cases, you may need to prescribe some topical antifungals or even some topical steroids or some combination thereof. But typically, it will just get better with some gentle scrubbing, that baby shampoo, and some moisturizer. Next one is dermal melanocytosis. This was formerly known as Mongolian spots. So for those nurses who are really experienced out there, you may remember them being referred to as Mongolian spots. We obviously don't say that anymore, but just for your reference, just to be more culturally sensitive, we call it by its more Latin name, dermal melanocytosis. Again, these are really benign. These are large grayish blue lesions on typically that baby's lower back buttocks area. I'm going to launch our next poll and ask you, how do you know as a clinician that this is dermal melanocytosis and not bruising? What do you guys think? What are some responses? So you see a baby coming in for that newborn visit. You see this large grayish blue lesion on their lower back and bottom. How do we know that this isn't abuse, right? Because that's one thing that we as clinicians need to always be thinking of and screening for. How do we know this is dermal melanocytosis and not abuse? Not painful. Okay. How's the baby telling you if it's painful? Painless. Bruising comes in various stages. I love that. Awesome. The color. The baby will cry if it's painful. What if that baby's just crying that whole visit, right? You can't really tell, right? Non-blanchable. I love that. Yes, absolutely. Yes, you guys hit the nail on the head. So various bruising typically comes in various stages. It's non-blanchable. If you have a very mellow baby who's not going to be crying, you can also touch it and see if they start crying. Sure, that could be a way to tell. But also because remember, if it presents at birth, it's not a bruise. But I love those signs that you guys are looking for to distinguish between bruising and a birthmark, a benign birthmark like this. Very nice. So you're going to find it also more commonly in infants with darker skin tone. So that can also clue you in as well, right? So Asian ethnicity are the highest likelihood, Black, Hispanic population. Again, we're going to reassure the patient's parents and make sure that they understand that this will fade in early childhood. They don't need to do anything about it, right? Because you might get some parents coming in being like, is this from labor? What happened? Did my baby get hurt? So you really have to do a lot of reassurance. Okay, cafe au lait spots. I don't know why I really like cafe au lait spots. Is that weird? So cafe au lait spots, also benign skin lesions. So remember we talked about the blue birthmarks. These are what? Cafe au lait colored. So also coffee with milk spots, also present at birth. These are going to be flat, light brown. They can also vary in size. But yeah, I did say they were benign, but if you have 6 or more, what do we need to be thinking about? I don't know if I did a Slido poll on this. I didn't know. What do we need to be thinking about if there are 6 or more of these cafe au lait spots? Oh, it's on my slide. And you'll see right here, you want to refer for genetic workup. There can sometimes be an association with genetic factors like neurofibromatosis, Albright syndrome associated with these cafe au lait spots. Again, if you're seeing a couple here or there, nothing to be worried about. But if you're counting quite a few, 6 or more, then we need to get our genetic counseling looped into that patient's care, right? But these really, they don't need any treatment. These are just cosmetic. However, some parents, some patients may want to have them removed for cosmetic reasons, and they can do laser therapy. But I highly encourage you to reassure your patients. You might see boards questions about, is this something that you're concerned about, or do you need to reassure? We always want to reassure our patients. Remember, they don't have the medical knowledge that we do, and you want to make sure that you're reassuring when it's not something that is of concern. All right, the nevus simplex. So this is also a birthmark, also known as a stork bite or angel's kiss. And you can see that You can see it on that upper lip of this child in this photo. These are also benign. Typically, they'll be flat and pinkish red, and they'll have little feathery borders. Typical area is really this upper lip, but you can also find it on the back of the neck, on the forehead. It could really appear anywhere on the body, but those are the most common places. This is a form of capillary malformation, meaning that it's a tangled web of capillaries, which is why we see that pinkish red color. So remember, the key here is if it becomes more red when the baby's crying, that's that increased blood flow, right? That's also really confirming it's that nevus simplex. These are incredibly common. Up to 30% of newborns will have them. So again, big takeaway, reassurance, 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 right? Reassure those parents. These do typically fade. So about 95% do fade within that baby's first few years of life. And for those that don't go away, you can get them laser removed. So some patients, some parents might choose to do that, but it typically does fade in those first years of life. Now, nevus flammis, also a benign birthmark, also known as port wine stain. And you can see in this picture why. It's got that beautiful dark purple color. These are flat, reddish brown, purple. They're a lot larger. And you'll commonly see it on the face of the neck like it's pictured here. Now, this is also a vascular malformation. We don't quite know the etiology, but there is possibly some genetic link, so it might run in the family. The key with this is that it does not disappear with age. And in fact, sometimes it grows thicker and darker as the patients age. So this is something that is benign. You can reassure patients, but it might be something that's really impacting the patient if they're feeling like, it's really visible, it's on the neck, it's on the face, I want to do something about it. This is something we'll see more commonly. Patients will come in for that laser treatment. Some more benign skin conditions, so melasma, brown, grayish patches. So typically we see this on the face, cheeks, forehead, nose. My next poll, what patient population do we commonly see melasma? What do you guys think? What is a patient population that we may commonly see melasma? And again, nothing to be done about it, just a lot of reassurance. Yes, look at you guys. Rocking and rolling. So I'm guessing African-American population is what you're saying, but pregnancy is what I was thinking about. So pregnancy, absolutely. Let's go back to that slide. So it's common in pregnancy because of all those hormonal changes. It's not harmful, but it certainly can affect mom's self-esteem. Remember, it's brownish, grayish patches. It might look like dirt in some patients, right? And so they get really self-conscious about it. Just reassure them that in that postpartum phase, it does fade, but it is tough because you really can't do anything about it during pregnancy. It's really caused by those hormonal changes. And you'll see as we're going through today's lecture with our pregnant moms with dermatologic conditions, there's not much to do. If there's a patient that's really distressed, you can always send them off to dermatology, have them get a second opinion. Dermatology might feel more comfortable doing certain things. Again, we're talking about primary care management of these dermatologic conditions. So in mom, you just have to reassure her that it does fade in that postpartum phase. Vitiligo, another more benign skin condition, though it can look very concerning to patients who don't know what it is. This is a chronic autoimmune condition, and this is when they start to lose patches of pigment in their skin. So those melanocytes get destroyed. So you start to see these white, light-colored areas. There is no cure for this, but there are various treatment options out there now, which is great. You may have seen some commercials about it. Definitely want to send this patient over to dermatology and see what kind of treatment options they can offer them. Next one is lipomas. These are fatty tumors. I won't go into the personal specifics of how much I know how to identify lipomas. I have lipomas, family members have lipomas, patients have lipomas, and it's always, a discussion about, is this a sebaceous cyst or a lipoma, and convincing patients that this is not a cyst that I can drain, this is a lipoma, and talking to them about what it is. It is a fatty tumor under the skin. So it's going to feel really squishy and it's going to be movable, right? It's a movable lump. So when it's squishy and soft and movable like that, how can you tell it's not a cyst? Once you start to feel lumps and bumps, you'll start to really feel the difference between a cyst where you can feel that fluid in there. So try it when you're especially going into your clinical rotations, try to really feel those things on your patients, right? You're a student, it's great. Even when you enter clinical practice as a novice NP, really get in there and start to really feel things, feel those thyroids, feel those squishy lumps and bumps. So you can really get a sense of how it feels different between that sebaceous gland, between those sebaceous cysts, which are fluid filled, and these lipomas, which are fatty filled. It's just a different consistency. This is more squishy, is the best way I can talk about it. But it is also movable and it can really grow anywhere. There's no need to remove them unless it really starts to push on a nerve and present in an area that starts to bother the patient. So typically these will get left alone and unless it really starts to really become painful or too big. Next one is lentigens or solar lentigos. These are also called liver spots. Once you see and learn how to identify liver spots, you can't stop seeing liver spots. And I just want to go and just spread sunscreen on everyone. So liver spots are really clumped melanin, and it's produced in those high concentrations in those sun exposed areas due to sun exposure, right? They're going to be really flat, brown, tan spots. Again, these are benign, but you do want to watch them. And it's really hard to look at different lesions on a patient's skin when they have a lot of these lentigens. So typically with these patients, I will send them to dermatology to do their annual skin checks, just because it's really hard to identify those really malignant and concerning lesions in that short primary care visit. I'll do my scan. I'll make sure I'm feeling them. None of them feel rough or raised, but I do want to make sure that I loop in our dermatology partners and they're doing a full head to toe skin check on these patients, right? Biggest thing for these patients, you want to educate them about that sun exposure and try to get them to really avoid sun exposure and wear that SPF. Most of them won't. You'll see these in the areas. I know I had a lot of people from Florida on the call tonight. You'll see this a lot in those areas where they just want to be out in the sun. I don't blame them. You live on the beach. Why not? Right? But please wear some sunscreen. And if you have a lot of them, refer them to dermatology. And then some of them, dermatology might think, you know what, we need to remove these. They might do some cryotherapy or laser removal of these lesions if they start to be concerned about some of them. Some other benign skin conditions. So nevi, also known more in lay's term as moles. This is just pigmented skin growth, so it can happen anywhere on the body, and most of them are harmless, but we want to keep an eye on them. And we'll go through we'll go through those signs in a minute, but we want to definitely make sure we're looking at our moles and knowing when we need to be referring out. So you see on here, it says always refer out changing lesions. Absolutely. And we'll talk about that. Now, the acrocorridans, or also known as skin tags, also benign. These are small little growths. Typically, you'll see it in areas where the skin rubs against itself or clothing. And it's soft and flesh colored. It does protrude. So it's kind of like a little thin skin lesion that kind of sticks up. Also, these are really easy to remove. I really like removing them. It's satisfying. It makes the patient feel like, oh, finally, it's not pulling on my jacket or skin. You do have to make sure that you do have the equipment that you need in your clinic to be able to remove them and just cauterize that area. And then it helps them out a lot. What can skin tags be a sign of, though? When you see a patient with lots of skin tags, what are we thinking about in terms of their overall health, and what should we be thinking about when we're looking holistically at these patients? So what are some things that we want to screen for? Yeah, absolutely. So diabetes, insulin resistance, absolutely, those metabolic issues, right? So insulin resistance, when I see a patient coming in with a lot of skin tags, typically all over their neck, I'll see it under their arms, I'll see it in their skin folds. Sometimes when it's really bad, I'll see it around their eyes. I do not remove the ones on the face. I was always taught face, hands goes to the specialist, especially with suturing or any kind of surgical procedure goes to the specialist. But absolutely, if we're seeing a lot of these skin tags, we want to think metabolic issues and we want to be screening for that and watching for that in these patients. Very good, you guys. All right, before we jump any further, so this is the email address I was talking about. I know a lot of you were talking about getting ready for your boards, getting ready, not sure where to start with your study plan. Definitely reach out to me if you can't find any mentoring or tutoring slots that are available online on our website. You can go to archerreview.fnp and go straight there and book something. I just noticed something on our slide. So and then we also, for those of you sitting for your boards exams in a few weeks, we have a 3-day live review coming up at the end of the month. So this is going to be 3 days, 9 to 4. We're going to cover everything from cardiology, respiratory, dermatology, HENT, neuro, psych, everything, exam anxiety. We're going to talk about the 2 different boards exams if you're just not sure the difference or which one's appropriate for you. We're going to talk about how to really interpret the information, the knowledge that you have, and really apply it and go confidently into your boards exam. So join us for that 3-day live review. I'm really excited about it. We've got a great team of presenters. We'll be on live, which is the really huge benefit of it. So you can ask whatever questions about that content area. These are experts who practice in that area giving the lecture. And I think they're all very strong presenters. You guys have probably seen them on the free webinar series, but definitely check that out and join us for that 3-day live review. You do get a workbook and a copy of all the slides. So it's a really nice deal. If you feel like I can't make the 3-day live review, I'm just not ready for it, or I'm testing before the end of the month, you can definitely utilize our question bank and our on-demand videos. And we have a combo package where together, if you're really, the sure pass method is if you're practicing 25 to 50 questions a day, you go back and watch those videos, and then you take our readiness assessment test. If you take 4 readiness assessment tests and you're scoring high or very high on 4 consecutive ones, then you can really feel confident going into that you're ready to sit for your boards exam. So we have really great data analysis that gives you that data of like where your knowledge gaps are after you've taken the readiness assessments, and then it'll give you your readiness predictor. So it's a really nice way to kind of feel like, okay, these are the areas I need to go back and study. Let's create a study plan. Let's make sure we're filling in those knowledge gaps. And then you can take those readiness assessments over and over again, and they're fresh new batches each time. And it'll tell you with that predictor when you're ready to really sit for the boards exam. So it's a really nice way to get you squared away for your boards. If you want to follow us on our Facebook group, we do post things like tonight's webinar, and you can go back and watch previous webinars. It will make announcements on there about free giveaways, discount codes, things like that. So it's a nice community to be a part of. We're also really expanding our advanced practice space and offerings and product line. So it's nice to keep watch on that because we're not just focusing on boards preparation anymore. We're really looking at the lifespan of the NP. So not just sitting for your boards, but how do we support those novice NPs getting into practice, coming with a lot more continuing education credits down the line very shortly. We're doing things very quickly here at Archer. And then also supporting those experienced NPs, right? Really building a community where NPs can all come together and we can talk about things that we really need more support in and provide those resources for you. So definitely make sure you join our community. It's a really nice way to keep in touch with us as we're building all that out for you. All right, I'm going to sit down because I'm getting chatty. All right, you guys. So going to our next poll. But how do we know when a skin lesion is not benign? What's that acronym that we were taught in school? And believe me, when I entered clinical practice, I would go through the acronym in my head. I would do old CART in my head for when I first started seeing patients because you get so nervous, right? And I know some of you said that tonight too, but that first job is really scary. I remember I was like sweating every day, and I wrote a blog about this back in March But I was bringing in clothes to change into at lunch because I was just so nervous. So when you get nervous, those acronyms can really be helpful. It looks like everyone agrees. A, B, C, D, E. Awesome job. So what does that acronym stand for, right? What are those things that we're looking for? So A is for asymmetry. So we're looking at a lesion, we kind of want to divide it in half and look at symmetry, right? Does this look symmetrical? And so if you divide this in half, absolutely not, right? Kind of looks like that flowery border that we talked about with those other nevi. So we want to really look at those borders. Is this a nice even border? Is it symmetrical? Absolutely not. What about the color? You see that color changing throughout the lesion. Some parts are dark, some parts are light, some parts are medium brown. That is also a red flag, right? And then the diameter, I remember in my pockets, I'd always have everything full of pockets, including a little ruler, right? You just get that ruler right out. And is the diameter larger than 6 millimeters? If so, again, concerning. And has it been evolving? So ask the patient, be like, has this been changing, right? Is this getting bigger? Is this growing? Is it elevated when you run your finger against it, right? So those are all really concerning signs, and we need to be sending them over to dermatology right away. I usually have dermatology partners in the areas that I practice that I can pick up the phone and call and be like, hey, can you get this patient in? Because dermatology, the wait is at least 6 months, at least in the areas where I've practiced. And so it's really nice to have that connection and that relationship with your specialist in the area. So when there's something that you see that's concerning, you can pick up the phone. Typically, it's talking to their nurse and the message gets relayed, but that's still better than just sending a fax over and they're waiting 6 months. So, skin cancer, let's talk about those malignant conditions. So, briefly, we're going to talk about melanoma. Remember, what is melanoma? Well, I'm looking at my polls. I'm sorry, I'm all mixed up with my polls tonight. Okay, I'm going to launch our next poll. And what is the most serious kind of skin cancer? What do you guys think? Is it melanoma, basal cell carcinoma, squamous cell carcinoma? What do you guys think? Did I give it away? Yes. No, I didn't give it away. You guys are awesome. You guys are awesome. Yes, melanoma is the most concerning, right? It's the most serious kind. So those A, B, C, D, E's that we just talked about, right? What are those? Is it asymmetric? What does that border look like? Is it changing? Is the diameter more than 6 millimeters? We definitely want to be thinking melanoma. Now, basal cell carcinoma. I keep messing up my polls. This is more of the waxy, pearly. You'll see it more in those sun exposed areas. So it is one of the most common types of skin cancer that we'll see. And then last but not least, squamous cell carcinoma. Can you remember what the precursor to squamous cell carcinoma is? And you can put it in the same poll if you guys are already there. What is that precursor to squamous cell carcinoma? I see some thinking. I see some typing. Very good, you guys. Awesome, awesome job. Actinic keratosis. Absolutely. And so with this one, you're going to really feel more of that rough, scaly skin. So remember what I told you, you guys always want to be feeling that skin. Does it feel rough? Does it feel scaly? Sometimes patients will also describe it as itchy, right? So that's definitely something that we want to freeze off because it is a precursor to squamous cell carcinoma. Again, depending on your clinical practice, if you've gotten training and you feel comfortable freezing those off, you can quickly freeze those off and then really encourage that sun protection sunscreen. If that's just not something you're comfortable with or not within your wheelhouse in your clinical practice, you want to definitely send it over to dermatology and they will freeze it off for you. All right, let's get into rashes. So starting with our first one, tinea. So tinea is going to be really common. You guys are going to see it a lot in primary care. This is what we also call ringworm. These are our fungal infections. And these are typically those ring-shaped rashes. They are raised on the border, raised scaly borders, and they're itchy and red, right? It is a fungal infection, so we do treat it with azoles. So typically topical But when do we know we need to treat it with oral? It depends on the body area. So on the scalp, typically we do treat it with oral. Also, if I'm seeing a lot of tinea, so if I see it's a big rash, I might hit that with oral as well, right? But when we are treating with oral, we definitely want to watch those LFTs and make sure that it's not contraindicated depending on what other medications that patient's on. A lot of psych meds do have that contraindication with azole, so you have to watch for that. Um, I was going to tell you guys a little bit about different cases, but I think we will move on to the next one. Now let's talk about the other rashes. I'm going down my list. And let's go to pityriasis rosacea. This is that herald patch, or it looks like a Christmas tree pattern on that lower back. Typically, it might show up originally looking like ringworm, but then it'll erupt into that Christmas tree pattern on the back of the trunk. That's what that picture 2 here is. So you can see that typical pattern. It's usually self-limiting, but you need to manage those symptoms because it's really, really itchy. So typically that patient will need some antihistamines and also some topical steroid cream. Remember, if you're putting topical steroid cream on it and it's getting worse, that's a good sign that maybe this is a fungal infection. So if it's fungal and you're putting that steroid cream on it, it's going to get worse. But typically it'll present like tinea, but then erupt into that Christmas tree pattern. We don't really know the etiology of pityriasis rosacea. We think it's viral. Again, it is self-limiting, but you have to manage those symptoms. Now moving on to lupus, that's our butterfly rash, pretty classic butterfly rash. It does spare those nasal labial folds. That's how we know the difference between lupus and other rashes that we see on the skin. This also is something that we want to make sure that we refer out to dermatology, just because lupus is an autoimmune condition. And if it's really something that we are considering, dermatology can always confirm it on blood tests. If you're like, this is definitely lupus, they need to go to rheumatology right away and start management, you can always go that route too. But I like to have dermatology do those skin biopsies. They can run some blood work as well, and that can really confirm our diagnosis. Now, the last one is herpes zoster. Also a viral infection. We do treat it with antivirals. It's the most effective used within those first 72 hours of symptom eruption, and it does follow those dermatomes, right? Let's launch our next poll and ask, what do we worry about when we have something like this erupting along that cranial nerve 5 or that trigeminal nerve? What are we worried about? Yes, absolutely. Vision loss, blindness. And why is that? Remember, that trigeminal nerve really branches out and there can be some eye involvement. Yeah, I love that emoji. Thank you, guys. Do you guys know I love emojis? I didn't say that in my rating, but I love my emojis. So absolutely, there can be some eye involvement. So we want to make sure that we treat this right away and loop in our ophthalmology partners. Let's go back to this picture, especially if we're seeing it in certain areas along that trigeminal nerve. If I see it on the tip of the nose too, I get really worried about, because if you look at pictures of the trigeminal nerve, I don't have it in this lecture today, but you'll see that it does go right there, right on the skin. So I really worry about eye involvement. Very good, you guys. All right, let's practice. I'm going to launch the poll while I read, because some of you definitely read faster than I do. So you can answer the question. The poll is open. But let's read it together. A 17-year-old male athlete presents with light and dark patches of skin on his trunk, back, and neck. He states the patches are not puretic, but he is concerned about the appearance of the scaly patches. He denies any other medical history, recent illness, or trauma. What is the most appropriate diagnosis? Is it A, B, C, or D? Do we think this is tinea versicolor, tinea corpus, pityriasis rosacea, or vitiligo? What do you guys think? Let's go to our poll. Give you guys a few minutes. Oh, we're neck and neck. What do you guys think? We need a couple more people to throw us one direction or another. It's kind of hard, right? Because we talked about that pityriasis rosacea being that Christmas tree pattern on the back. But then it does present like tinea at first. So is this tinea versicolor or pityriasis rosacea? All right, so it was tinea versicolor. And so typically when you take our questions with our question bank, you'll get the rationale. It also links to the videos for that section, our on-demand videos, which is really nice. And it gives you a really robust rationale. So this is tinea versicolor. Remember, that's a fungal infection. It's typically caused by overgrowth of yeast on the skin. They were giving you some clues in this one, right? This is an athlete, probably sweats a lot. So also cluing you towards tinea versicolor, right? And it's easy to identify because they also described the spots as light and dark areas of skin. So typically we see that with tinea versus that pityriasis rosacea, which is more pink and scaly rash. So really trying to visualize those rashes when you're answering these questions is going to be really helpful. We typically treat tinea versicolor with those azoles, so the ketoconazole, typically 1%, or any other antifungal topically treated. All right, guys, let's get into some skin infections. So who wants to guess what these skin infections or these pictures represent? I'm going to go to this poll, and this is an open text poll. So what kind of skin infections are these? So you can write like picture 1, picture 2, picture 3, but who wants to guess what we're looking at? So what are we looking here in picture 1? What are we looking at here in picture 2? What are we looking at here in picture 3? What do we think this is? Give you guys a few minutes before I go to the poll. Okay, getting some responses, some people thinking about it. Take a good look at the pictures. I always think in my disclaimer, I should say I'm going to put some pictures in this webinar. So don't eat your dinner or lunch while you're watching the STERM lecture. I see some typing. Oh, people coming out the gate with all 3. I love it. What do you guys think? Okay, we got some cellulitis, boils, severe acne. I love that. Lipoma, folliculitis, furuncle. I love it. You guys are pulling it all in. Awesome. All right. Dun, da, da. So picture 1 is cellulitis. So this is a pretty nasty case of cellulitis. I've never had cases this bad, which is really great. I think this is definitely an inpatient kind of thing. If you're really seeing all that breakdown, this looks like a geriatric patient who's not really being well taken care of. So typically you're going to see that bright red, painful skin with cellulitis. But if you're really seeing all this pus, purulent cellulitis, you definitely want to be thinking about MRSA and hitting it with those BCD, so Bactrim, clindamycin, or doxycycline. But typically, if it's in that outpatient world, you're seeing that bright red, painful cellulitis, it's caused by that Staph aureus that lives on the skin. Typically, you'll have some breakage in the skin, and that Staph aureus goes in there and creates a nice little warm bed for itself. And the first line treatment is really those cephalosporins or the penicillins. But if we're really thinking really bad case like this, we're going to be hitting it with something a little harder. And I'm going to definitely get my wound care specialist involved in this patient's care. Next one is folliculitis. And so this one's kind of hard. I know some people said acne. It's really hard when you can't see the whole picture of the whole patient, right? So you're not the first one to think severe acne. This is folliculitis. So that's when we just have those hair follicles infected, right? And that typically will use some topical Bactroban on this. But you can see the clue there was that really it's at that root of those hair follicles. This one's a furuncle or boil. I saw a lot of you got that, so awesome job. And typically with this, we do treat it with those penicillins. Typically, I do like to do an incision and drainage on these, except for where? Where do we not do an incision and drainage? And I think I gave my next poll away, but what if it was located over a joint? Why would we not be doing an incision and drainage? What would we be worried about if it was located over a joint? What would you be suspicious for? Yes. Osteomyelitis, absolutely. So where would you send this patient? Would you treat them an outpatient? What would be your next step for this patient? Yes, absolutely. Osteomyelitis, and we would be sending them over the ED, and this patient would most likely get admitted. Absolutely, you guys. Very good. Awesome, awesome job. You guys are all going to be safe clinicians out there. I love it. All right, going to our next poll. Poll 14. What are our guesses? What's picture 4? This is the same condition, but 2 different types. What's picture 5? What are some guesses? What do we think? What do we think? What's picture 4? What's picture 5? All right, I see one response. Somebody's guessing. All right, some people are typing. I got impetigo, molluscum, impetigo and molluscum, contagiosum. Look at you guys. I love it. Yes, absolutely. This is impetigo and this is molluscum contagiosum. Let's talk about these two conditions. So impetigo, typically you'll see this honey crusting, right? Honey colored crust. Typically you'll see it on the face or the extremities. It is highly, highly contagious. Okay. This is a bacterial skin infection typically caused by staph or strep. We have 2 different kinds. We have non-bolus and bolus impetigo. Typically, non-bolus is the most common. These will see those smaller, more itchy sores that rupture and ooze, and they develop that honey crusting color. And typically, we'll see it on the face, like you do in this picture, around the nose and the mouth. You can also see it on the hands. Bolus impetigo is that blistering, right? This is more severe, and we would have to treat this more with those oral antibacterials, right? Antibiotics. So you could do it with both oral and topical. These are going to be larger, more fluid-filled blisters. They may stay intact for longer than that non-bolus impetigo before bursting and rupturing into that yellow or brownish crusting. Typically, we'll see this more on the extremities, and we'll probably see more systemic signs and symptoms like fever, swollen gland. That's going to be more common. Both will resolve in 7 to 10 days with the appropriate treatment. Molluscum contagiosum, this is different, right? This is a viral skin infection. So bacterial, viral, right? Also highly contagious, spread from skin to skin contact. These are going to be really small, raised, pearly bumps or sores that you see pictured here. These bumps have a little small dimple in them in the center. So that's a good way to know the difference between this and some other lesions. Again, it's spread skin to skin contact. So you want to really educate patients not to share those personal items like towels. And then it may lead to secondary infection. So making sure we're watching for that, tell them not to pick it. It is self-limiting. You can get rid of it, but it does resolve on its own. One thing to note, if we see it in that general area, we definitely want to be screening for abuse. So remember on your boards exams, especially the ANCC, screening for abuse, things like that in your professional role are topics that are fair game. So you want to be thinking about that. And in clinical practice, you want to be thinking about that. All right, you guys, going to our next poll. And I'm mindful of the time. I do get chatty, so I think we might have to wrap up a couple polls and then wrap up for the night before getting into my favorite section, which is acne. Okay. Well, let's do a couple of practice questions. So 32-year-old male patient complains of an area of pain and inflammation in his left lower leg. He is alert and oriented. He has the following vital signs. So blood pressure 128/70, heart rate 72, respiratory rate 14, temp 98.9. Upon exam, there's no evidence of penetrating trauma or infection to any other locations. The patient denies a history of injection drug use and known MRSA infection or colonization. The patient has no comorbidities. You diagnose the patient with cellulitis. What antibiotic should you prescribe? A, B, C, or D? What do you guys think? Are you going to be giving him Vanco, cephalosporin, cefepime, or Bactrim? What do you guys think? Oh, we're neck and neck. Neck and neck. Yeah, so the right answer is cephalaxin or Keflex, right? So Keflex is going to be our first line with this patient. So, oop, did it jump around? So remember, Keflex is our preferred treatment when it's uncomplicated cellulitis, which is the case in this patient. So we want to make sure they're telling you that his vital signs are stable, everything's stable, no MRSA colonization, no history of MRSA. So for him, we're really going to be doing something like Keflex. What were the other options? I think Bactrim was the other one. Which option was Bactrim? Let me go back and take a look. Bactrim was D. So with D, so that's really good. We're going to reserve Bactrim for if we're suspecting MRSA. And they told you flat out that you're not suspecting MRSA in this case. This is uncomplicated cellulitis. And then with cefepime, this is more that broad spectrum antibiotic. And we really want to be reserving this more for that inpatient side if we're really thinking about patients who are getting really sick, going more towards sepsis. And then I think vancomycin also, we want to reserve that. So that's going to be more if that patient has more systemic signs or symptoms and their vital signs were perfectly stable. So Keflex, again, first line for that uncomplicated cellulitis. All right, Mr. Neely, an 82-year-old male patient comes in from assisted living unit to your clinic to get medication refills. He complains of pain and swelling over his acromion process. And upon further exam, you notice a furuncle has developed in the area. Where do you refer him? We kind of hit on this already today. A, B, C, or D. What do you guys think? Absolutely. The emergency room. Yeah, we definitely want to make sure that we're thinking about osteomyelitis. Very good, you guys. So with a few minutes left, I'm just going to go over and hit the main points of acne because it is my favorite part of my derm lecture, but we are running out of time. Acne, remember acne vulgaris, it's going to be something that's really psychologically distressing for your patients. It can cause a lot of disfigurement, can cause also discomfort in patients. If they're not comfortable in their skin, it's really an issue, right? It affects their whole self, their quality of life. It's a chronic skin infection that really those hair follicles become clogged with oil, dead skin cells, bacteria. And there are different types of lesions. There are comedones, papulopustule lesions, nodular lesions. These are more of those deep-seated, rooted lesions that are really painful and inflamed, and they're going to be more than 5 millimeters. Those comedone lesions are more going to be superficial, non-inflammatory, and those are more of our whiteheads and blackheads. And then we have the in-between, those papular-pustular lesions as well. So acne severity, there's no universal scale for acne severity. We really have to do a good job of establishing etiology. So think about it. Is it a hormonal cause of medication, skincare products? Is it an underlying endocrine issue? You really want to be getting your patient involved with how distressing it is for them when you're thinking about their treatment options. And then you can kind of scale it. I really group it in my brain with mild and then moderate to severe. Mild is more of those scattered lesions. There's really limited skin involvement. And then moderate is when there's multiple skin area involvements. I'm seeing some nodules. I'm seeing some associated scarring, and it's visually really prominent. Also lots of different treatments. This is in our wheelhouse in primary care to help our patients with acne. Sometimes we do have to send them out when we want to be considering those oral retinoids, but everything else is within our wheelhouse. And again, dermatology is a 6-month wait. So if we can get comfortable with treating our patients' acne, this is going to be really something that improves their quality of life. We have topical treatments, we have oral treatments. I've kind of broken it down to 2 categories between, again, mild in one category and moderate to severe in another. Those milder acne vulgaris cases, you can really treat it topically. Biggest thing to know about topical treatment is education. Know your contraindications. Typically, pregnancy, again, very much a big no-no with a lot of these things. Not much we can do for our pregnant patients. Send them over to dermatology. Maybe they'll feel like they can do something for these patients. But typically those topical treatments, you can try those topical antimicrobials with topical retinoids. Remember, you never want to prescribe just a topical antimicrobial by itself because it does lead to resistance. Moderate to severe, we're going to do topical along with oral. So again, think about the etiology. You have some oral options that are antibiotics. So typically tetracyclines are preferred. Those are our first line. Again, look at your contraindications, contraindicated pregnancy, young children. We have our hormonal options, right? So if this is hormonal acne, maybe a good case for someone to start on those oral contraceptives or spironolactone. Definitely want to look at contraindications again and those adverse effects, monitor for those. And then in some cases, you are going to send them off to dermatology and you're going to manage them until they get there, right? You have to be a qualified prescriber through the iPledge program to prescribe Accutane, which is that oral isotretinoin. Because of that teratogenic effect or side effect, it does have a black box warning, and patients have to also take the iPledge and make sure that they're preventing pregnancy and getting routine pregnancy tests, and all of that goes along with it. But I've seen oral isotretinoin do wonders for patients. So definitely not something to shy away from if you're really seeing a severe case, but something that you can be doing while they're waiting to get in to see dermatology. So I know that was kind of fast, but I didn't want to skip it today. Remember, counsel your patients. Don't pick at the lesions. It just pushes the bacteria deeper in. It causes more inflammation. Talk to them about their expectations and set realistic expectations. There's going to be, improvement is not quick. You're going to have to make some adjustments to the regimen, and some patients may require long-term maintenance therapy. I'm going to skip past this for today just because of timing, and wrap up with making sure that you guys have my email in case you have any questions, need any help, and you join us for our 3-day live review. And at the very least, you join our community so that you can participate. Tomorrow, I am giving a EKG lecture at 10 a.m. Central Time, so please join me for that. And I will hang on for a few minutes if anybody has any questions and check the chats. But you guys have been an awesome audience. Thank you so much for joining me today. It's been a while since I've given an evening lecture, so it's nice to see everyone joining. You can also throw in the chat whether you like these evening hours, if they work better, if we get more student participation with these evening hours. I'm kind of curious to see that as well. I'm going to launch our very last poll because I said I would, and it would help us collect this information about how confident you feel after today's lecture about managing those common skin conditions. So before you guys hop off, if you guys can definitely let me know how you're feeling, that'll make me feel like, okay, I know what to do for the next lecture. We can adjust, don't have to adjust. I'd love to hear back from you guys. And as some of you already know, I am very responsive on email, so don't hesitate to reach out to me if you want to see something else in these free webinars. Give us your feedback. We'd love to hear it. And I'm seeing some people overall feeling a lot more confident, which is great. Where is my friend who was already at a 10 before we started? I hope you didn't go backwards. I hope we didn't regress, but I'm sure you just hopped off. But I'm so glad to see overall everyone's feeling a lot more confident. So that is awesome. And Jacqueline's asking, will there be a printout for the review? Yes, our 3-day live review, you will get the printout of all the slides, a PDF printout of all the slides, as well as a workbook. So very, very nice material to have for all that high yield content. Absolutely. Great question. And I'm just checking the chats just to see if I missed anything. All right, you guys, thank you so much. I really appreciate you guys. Enjoy the rest of your evening, and I'll see you next time. Have a wonderful night.